Everyone. So excited to have this talk today, and we truly have a treat in Dr. Joly. I'd like to uh, introduce Joanna Joly. She's an assistant professor in advanced heart failure and transplant section in
Are
the
you
division of
listening to this?
cardiology here at UAB. Originally from Washington, D.C., she received her medical degree from Georgetown University. She has her cardiology fellowship here at UAB, and then in 2018, completed a fellowship in advanced heart disease and transplant cardiology at Harvard, at the Brigham and Women's Hospital in Boston. I just want to say I've had the privilege to personally work with her. Not only is she an excellent clinician, but just overall a very personable doctor, a wonderful bedside manner. Her patients love her. She knows them very well by name, is very, very involved in their care. And it's one of those doctors that if you have her taking care of you or taking care of one of your patients, you can relax because you have truly an expert and someone who's really invested. I'm so excited for her to talk to us about cardiac conditions of pregnancy. And with that, I'll turn it over to Dr. Joly.
Thank you very much. That was the best introduction I think I've ever had. So I wish I recorded it so I could hear it again on bad days. So thank you so much again.
We've got it recorded for you, Dr. Joly.
What was that?
I said, we've got it recorded for you.
Oh, perfect. Good. So, well, thank you very much again for hosting me and allowing me to come chat with you all today about cardiac conditions of pregnancy. So I'm just going to dive right in and get right to it, and we'll go ahead and start. So my objectives today, we're going to recognize red flag signs and symptoms in pregnancy. We're going to review some cases of cardiac disease in pregnancy, select appropriate medications across the pregnancy and postpartum continuum. I think that's sometimes one of the most challenging things, at least for my fellow cardiologists. And then lastly, we'll appreciate the utility of biomarkers and team-based care in assessing patients who's sick, who's not, and recognizing the role for team-based care and how sick these patients are. So the first thing we'll talk about is recognizing red flag signs and symptoms. So the main red flag symptom that I want to highlight is dyspnea in pregnancy. Very challenging because a lot of women who are pregnant have symptoms of dyspnea or shortness of breath. And what the concern is that, the potential for underestimating severity, sort of assuming it's just pregnancy, it's really nothing serious, and then lead to inadequate investigation, which can then cause some of the maternal morbidity and mortality that we all really hate to see. There was a French, and this is not just us, there's a French nationwide analysis from 2007 to 2015 that noted that 13% of all maternal deaths were attributed to cardiovascular disease. Among the 23 women whose deaths were determined to be preventable, they found that a missed or delayed diagnosis of heart failure in the context of acute shortness of breath was the main preventability factor. Maternal mortality in Alabama is 41 per 100,000 births, and then compared to the U.S., which is only 23.5. So we have a good bit of work to do in this state, and why I think talks like this and getting the word out and talking more about what those sort of red flag signs and symptoms, why that can be really, really important to help bring that metric down in the future. So the most important thing is at whatever level you are assessing the patient is to get a thorough history. So when someone is complaining of shortness of breath in pregnancy, ask about, is there any associated wheezing? Are you coughing? Is there chest tightness? That could be a sign of asthma that is sort of worse during pregnancy. A pulmonary referral could be very helpful. Routine CBC could find anemia. I think from what I've seen, we are all getting a lot better about treating anemia, which is very helpful. If the shortness of breath is sudden onset, if it's pleuritic, which means that there's pain, chest pain associated with that shortness of breath, there's coughing up streaks of blood, or when you walk them around the halls in the clinic, is their oxygen desatting? Are they dropping down to less than 90%? And do they have risk factors for DVT, recent surgery, some immobility, inflammatory conditions that could make people a lot more prone to developing DVTs and thus PEs? Or is it sort of an infectious vibe? Does the pregnant lady have a fever? Is there a productive cough? Have they had risk factors, been around sick people? So obviously we're worried more about pneumonia or bronchitis in that situation. The questions I always ask about are whether the patient is having orthopnea, which is basically shortness of breath when they're laying flat in bed. Are they propping their head up in order to sleep? So using more than a pillow or two to sleep, or sleeping in a recliner, or sleeping on their couch because it's more comfortable breathing-wise. That is always going to pique my ears for this potentially being heart failure. Or paroxysmal nocturnal dyspnea. So at night, nocturnal, you would think that you are not short of breath because you're at rest, you're able to sleep. But if people are having to sort of sit up or even stand up or pace or use a fan because they can't get comfortable laying flat, that's when fluid sort of settles out in the lungs and makes it more difficult to breathe, then that could be a sign of volume overload and heart failure. If they're also peripheral edema, swelling or palpitations, and then they really can't do their activities of daily living. So those are all things that together especially point to potential heart disease. And then I'm always asking about syncope too. So if anyone is specifically exertional syncope, that would be a worrisome sign for pulmonary hypertension that has not yet been diagnosed. The physical exam is really important, so we're always going to look at vital signs. Blood pressure, of course, we have very specific guidelines now on that we don't want it higher than a certain level. Heart rate too, especially in known heart failure, we want to be paying attention to that heart rate. If we see jugular venous distension, that we know there's extra fluid on board, and so we're going to want to decongest. Same with lower extremity edema. The objective data we can get, we use 6-minute walk tests, biomarkers. I'll have a couple slides on specific biomarkers that anyone can check and get a sense of how worried we might be about someone's cardiovascular disease in pregnancy. 12-lead EKG, of course, an echocardiogram if I had my way. Every single pregnant woman everywhere would get an echocardiogram, but as of right now, that is not the case. But certainly if they're complaining of shortness of breath, I think pulling the trigger quickly on an echo can only be reassuring. A rhythm monitor in cases of palpitations, we need to better identify what rhythm is going on. Chest X-ray, pulmonary function test, vascular ultrasounds if we're worried about DVTs, and then contrasted chest CTs or other CTs, especially if we're worried about a PE. So we're going to keep moving through the objectives here. So we're going to talk sort of at the same time. We'll review some cases of cardiac disease in pregnancy, and then talk about selection of appropriate medications and sort of tips and tricks and things to sort of point out about these different cases. So we'll go ahead and get started with case 1. So this is a case of peripartum cardiomyopathy. This is a 22-year-old female with a past medical history of type 1 diabetes, gestational hypertension, obesity, asthma. She presented at 34 weeks gestation with dyspnea on exertion and lower extremity edema that had been going on, kind of just getting worse over the last 2 months, and she was admitted for preeclampsia. At her local hospital, she received IV antihypertensives and magnesium. She was given betamethasone in anticipation of early delivery, and she was then transferred to us here at UAB for management of her preeclampsia. On arrival, her blood pressure was 156/70, her heart rate was 100. She was initially given nifedipine. On labs, it showed an anion gap metabolic acidosis with respiratory compensation and ketonuria that was consistent with basically diabetes or DKA. And that she was initiated then on an insulin drip And her protocol given 4 liters of IV fluids on hospital day 1, again, to treat that diabetic ketoacidosis. She also had symptoms of an upper respiratory infection and was confirmed to have rhinovirus. On hospital day 3, she developed acute respiratory distress overnight. Her chest x-ray showed pulmonary edema, and her BNP at that point was 452. Upper limit of normal is 100. So she received IV Lasix, furosemide, and felt mildly improved. With an echo pending, the L&D team then proceeded with delivery for severe preeclampsia, and she had her induction started with oxytocin. On hospital day 5, she had an uncomplicated vaginal delivery of a healthy but premature baby girl, and her plan was to breastfeed. Post-delivery, her echo showed an EF of 35 to 40%, which was new. Go ahead and just show you. So this is an echo. It's a short axis version. And so what you can see, I hope you can see my cursor, that's the left ventricle. This is the right ventricle. And what you can see is that left ventricle is not contracting in as much as it should or otherwise would, but it's not terrible. So I would agree with the read of about 30, 35%. And then you can see the significant congestion on chest x-ray in that second shot. Our advanced heart failure team was consulted and the patient was massively volume overloaded. Of course, she'd gotten 4 liters of fluid, so on top of pregnancy swelling. She had 4+ pitting edema up to the hips. So she was visibly dyspneic and had some orthopnea and some chest discomfort, especially with laying flat. So she was always propping herself up. So we aggressively diuresed her over the next couple of days with IV Lasix. We changed her nifedipine to enalapril and added carvedilol, and we titrated those to a goal systolic blood pressure of about 100 to 120 and a goal heart rate to 60 to 80. This is at rest. She was finally able to sleep fully flat in bed, and her swelling was almost completely resolved. She was then discharged to stay locally. Her baby was still going to need time in the neonatal ICU, but was doing well. So we were actually able to see her a couple days post-discharge, 3 days post-discharge. Again, because she was staying close to the hospital made it easier. She actually had some symptomatic hypotension in clinic, and so we actually reduced the doses of the carvedilol and enalapril. In fact, I think we were actually able to discontinue them entirely at that point, and we changed her Lasix only to as needed. At her most recent follow-up, she was feeling well and euvolemic. Her blood pressure was 100/73, and her heart rate was in the 90s, and a repeat echo was pending. So good choices for routine pregnant patients with hypertension. Our sort of main 3 that we think of are labetalol, nifedipine, and methyldopa. And those are all solid choices. It's key to manage blood pressure in pregnancy and postpartum. Our goal is 130s over 80s or less, and that was confirmed by the CHAP trial here published in the New England Journal of Medicine in 2022. Super proud to be at the institution where we led that trial. And then preeclampsia and hypertensive disorders of pregnancy are significant risk factors for the development of cardiovascular disease in the future, and so that really warrants closer monitoring. So anyone that has a history of preeclampsia or hypertension during pregnancy, we really want to make sure we're following them closely. It connotes a 4-fold increase in long-term heart failure. So if they haven't developed it already, there's a good chance they may very well in the future. And so we never want these women to be too far from a cardiologist because of their potential risk. So those are good choices for patients who just have routine hypertension. For pregnant patients with hypertension, when they have LV dysfunction also present, these are the ones I prefer. Metoprolol, and the European Society for Cardiology also says that carvedilol is fine. I've used both. Metoprolol doesn't have as much of a blood pressure effect as it does heart rate, whereas carvedilol is much stronger, more potent blood pressure agent as well because of its alpha blockade properties. If additional medications are needed to control blood pressure in the setting of LV dysfunction, my go-tos are hydralazine and nitrates. Typically, we would use ACE inhibitors, ARBs, ARNIs, so those would be like lisinopril, losartan, and Entresto. The MRA would be spironolactone. We'd have Farxiga, Jardiance on there. Those are sort of the cornerstone for treating LV dysfunction. Obviously, in pregnancy, it's a different story, and all of those, including calcium channel blockers, which we never really like to use in LV dysfunction, those are all not ideal in pregnancy, so avoid them. Or take them off if you're seeing someone who is pregnant and on them. So blood pressure and heart rate goals are probably similar to non-pregnant patients with heart failure. So for me, the goal systolic is about 100 to 120s. The goal heart rate is anywhere in pregnancy, I think from 60 to 100. Again, the heart rate has to sort of rise throughout pregnancy just to sort of help maintain cardiac output and placental perfusion. And that's comparatively to, heart failure patients who have no, to heart failure patients who are not pregnant. The goal there is 60 to 80. So we allow a little bit more tachycardia or relative tachycardia in pregnancy, but still ideally less than 100. I ask all my pregnant ladies to monitor daily because I want to know trends. I want to know if we are optimizing them as best we can, especially those who have LV dysfunction. There's not enough data for ivabradine, so we tend to avoid that one. That is a medication that really just helps keep the heart rate low if beta blockers aren't doing it. Then postpartum, if LV dysfunction is present and the woman intends to breastfeed, we bring back enalapril. It's safe in breastfeeding, and so that's our go-to. We do bring back spironolactone too, but I usually do that only if I'm maxed out on the beta blocker and the enalapril at that point. The spironolactone is good from a heart failure standpoint. Like diuretics, it can decrease milk production, so just need to kind of have that conversation with the woman, or if they are on a little bit of diuretic and we're having to replete their potassium a lot, the spironolactone can be very beneficial in that setting. So it's mainly about symptomatic management throughout pregnancy and breastfeeding. Again, we're not able to give them medications that can modify and alter their long-term natural history of heart failure because they're contraindicated in pregnancy. So we can really focus on symptom management, and that involves loop diuretics. And we can also add digoxin too, especially when the ejection fraction is low. I'll add that one on. It's safe in pregnancy and could potentially be a little bit more helpful in terms of decreasing hospitalizations. So the main learning points, I think here, close follow-up is ideal. I mean, we went from fairly high doses of these medications to pretty much discontinuing them after a matter of days. There are significant physiologic changes that happen at the time of delivery and then immediately postpartum. And so we are often finding the need to adjust doses, sometimes titrate up, sometimes titrate down. And so close follow-up is key. Following the ejection fraction with serial echoes can be the key to understanding future risk. And so we'll talk about the specifics of that. So the risk regarding subsequent pregnancy, a lot of women talking to me about this before they undertake another pregnancy. And it's really important to kind of share the dichotomy here. So women who have persistent LV dysfunction, less than 50%, meaning they may develop heart failure during a pregnancy, and their ejection fraction, despite everything we're able to do, it never recovers past 50%, never gets up back to normal. They have a very high risk of recurrence of heart failure during a subsequent pregnancy and deterioration or worsening heart failure and mortality during a future pregnancy. Death rates are variably reported, but anywhere from 16 to 25%. There's also higher rates for fetal outcomes, such as stillbirth and preterm delivery, and I kind of share that also with our moms. I do think the hypothesis that is relevant here, and that we have a really strong cardio OB, high risk pregnancy team that I think it seems like anecdotally our outcomes are good when these women are followed in the context of this multidisciplinary coordinated care team, but that's really hypothesis generating. So on the other hand, that's one group. On the other hand, women who then experience improved ejection fraction, so they get back up to 55%. That's with good medical therapy. It's been 3 years since their last pregnancy. They've actually been off of medications now for a year because it's improved, and then they weren't able to tolerate them now, and they want to know about their risk for this happening again. they definitely have a lower risk of mortality and complications with a future pregnancy, but there's still some risk there. And we quote it as about 20% of it happening again. That said, about half of those patients who do have some sort of relapse tend to recover as they did the first time around. So there's definitely a dichotomy there in how people do based on whether or not their ejection fraction recovers. We'll just jump right into case number 2. This is heart failure in pregnancy. 37-year-old female with a past medical history of congestive heart failure due to non-ischemic cardiomyopathy with an EF of 30%, hypertension, type 2 diabetes, obesity, and she's a current smoker, presented to the emergency department with worsening dyspnea and edema. She had not followed up with her prior cardiologist. An echo confirmed an EF of about 30%. Her BNP is 3 times the limit. Blood pressure is 100/65. She was found to be 10 weeks pregnant. So she was referred to the cardiac obstetrics clinic, including maternal fetal medicine and heart failure. She was counseled that continuing the pregnancy was high risk. And this was a WHO class 4 by ejection fraction and potentially NYHA class at that point. She was started on low-dose metoprolol and furosemide with improvement. Her furosemide was then made as needed. She opted to continue the pregnancy, as many of our patients do, and we recommended strongly that she quit smoking. She did quit smoking. She's at 16 weeks, 6 weeks later. She's doing much better. She was able to do an office job and do her household chores. Blood pressure and heart rate are still in pretty good range. EF is stable at 30%. She's taking Lasix only about once every week or 2. At 19 weeks, 3 weeks later, she was hospitalized briefly for volume overload and required some IV diuretics. She was discharged on Lasix, now made 3 times a week, so a bit of an increase there. Fast forward to 28 weeks, she's able to do her office job and chores, but she needs to rest more often. She notes new orthopnea. Her EF is still stable at 30%. She's still following with our clinics frequently. We have gotten her to 34 weeks. She comes to clinic and she's visibly dyspneic and volume overloaded. Her EF by echo is dropped to 20 to 25%. Her BNP is up to 680 and she's got an AKI. So we have a multidisciplinary meeting involving these different services and discussed a delivery plan. So I'll quickly kind of share what her echo looked like. So this is a parasternal long axis. You have the right ventricle at the top and then the left ventricle here. You can see, maybe at least compared to the one before, this one's hardly moving. I mean, there's no contraction here. It should kind of come in completely, and it's not doing that. So I would agree that's low, 20%. And then you can see the significant congestion in her chest x-ray. So she's volume overloaded. So she was urgently admitted. We got IV diuresis, telemetry, and the plan was for hemodynamic optimization. So we did a right heart catheterization on her. We were concerned about her cardiac output, and one of the concerns mainly that drove us to do that was her acute kidney injury. We're worried that her organs aren't getting good perfusion, and so we did that, found very high filling pressures. I don't expect you to have sort of the normal reference ranges in your head of these, but just suffice to say these are very elevated filling pressures, and the cardiac indices here of 1.9 is quite low. It should be normal, is anywhere from 2.2 or so to in the 3s. So she was diuresed to a venous pressure of about 12. So she was definitely decongested, and her metoprolol was switched to hydralazine. The main reason for that is to sort of take away that negative inotropic effect and allow it's better long-term, not sort of an acute heart failure. So we tend to get rid of the beta blocker in acute situations. We did start her on dobutamine, that she was at 35 weeks now. We started her on dobutamine based on those pressures for inotropic support. We attempted induction, but she failed to progress. She then underwent successful C-section with neuraxial anesthesia and had a tubal ligation at the time. She had some mild pulmonary edema, which was managed with BiPAP and IV diuresis. She had a healthy baby boy, and she was monitored in our cardiovascular ICU. The dobutamine was able to be weaned off after just 2 days, despite her low EF. She elected not to breastfeed. We were able to get back the metoprolol restarted. She tolerated it well. She was stable on daily Lasix. We got a life vest fitted for her because without prior good follow-up, she did not already have an ICD, and certainly she would qualify for it if her ejection fraction did not improve with good medical therapy. And so after about 2-3 months, we would recheck and see. So mom and baby were able to be discharged home. So we saw her 1 week postpartum. She was able to do all of her activities of daily living, take care of her baby. She did not have any orthopnea. She was still losing weight. At that point, we started her on the Entresto, which we were able to do safely given that she was not breastfeeding. 8 weeks postpartum, her ejection fraction had improved up to 35 to 40%. That allows us to avoid the placement of the ICD. So past that 35% cutoff, she was no longer a sort of the high-risk group for developing a potential fatal arrhythmia. So we were able to discontinue LifeVest and table the discussion of the ICD for now. We stopped her hydralazine, got her on the 4 pillars of medications for long-term management of heart failure. That included the spironolactone. Her BNP over time improved. We did genetic testing on her that revealed a pathogenic variant, and so the pediatrician the plan was to arrange genetic testing. So she continues to follow with our clinic. We continue to manage her guideline-directed medical therapy. Her EF has stayed around 35 to 40%, but she's been well compensated and has not required any future hospitalizations. So this really highlights the challenges in managing cardiovascular disease during pregnancy and emphasizes the need for this multidisciplinary care and individualized treatment approaches. So some keys to point out here is that, we initiated her on metoprolol when her systolic blood pressure was right around 100. And so, that's not necessarily too low. Again, metoprolol compared to carvedilol doesn't have much effect on blood pressure. We really use it to help drive down that heart rate and try to maintain some stability. We did have to pull it off when she did come in acutely decompensated, but we do try to push these medications as much as we can. What was especially worrisome about her case and what I was trying to sort of illustrate was the trend. So the hospitalization trend, how that was increasing, how her diuretic requirement was increasing, how her NYHA class, what she was able to do without symptoms or before symptoms started was, becoming less and less. And so her NYHA class was progressing as well. We do trend that BNP and troponin throughout pregnancy, and I have a couple slides in just a few minutes to kind of share why that is the case and how they can be helpful. So team-based care really allowed for this smooth transition from the outpatient setting where we were seeing her acutely decompensated to the inpatient management. We reserve right heart catheterizations. We don't do them very often in pregnant ladies, but we do have to occasionally, especially for patients who continue to have symptoms of heart failure and specifically signs of poor perfusion despite adequate diuresis. And it can be safely done as long as we sort of cover up the gravid uterus, especially later in pregnancy, that the risk is not quite as high, but regardless, we were able to cover it up with lead very easily. And so the main issue is just whether or not, someone with a decompensated heart failure can lay flat, and we often have that issue. So sometimes we have to use a little wedge or something. And so we try to do it quickly and get the information we need. We can kind of move through this, I think, pretty quickly. Suffice to say, the filling pressures were very high, more than twofold what they should be. The pulmonary pressures, so that's the PA pressure 56/22 with a mean of 39. That would be considered pulmonary hypertension. In this case, it would be driven by WHO group 2, so driven by left-sided heart disease. In that case, there's no indication for pulmonary vasodilators, but, still strong indication to diurese as much as we can. I want to highlight this really lovely chart about the hemodynamic changes that happen from baseline throughout pregnancy and postpartum, specifically the cardiac output, the stroke volume and heart rate, and how those are all, how they achieve such a significantly increase of cardiac output by A, increasing the heart rate, B, increasing the stroke volume, so increasing the contractility, and mainly by decreasing that SVR. So the afterload in the body, the overall pressure in the body drops a good amount, and that allows for more cardiac output as well. But what you should see is that just after, I guess, close to 16 weeks or so, the cardiac output can be increased by about 50% compared to baseline numbers. And so if you go back to where we were looking at those hemodynamics, the cardiac index of about just 1.9 or 2.1 is a lot lower. And in fact, it should be even higher than the numbers I was quoting before, which was sort of normal for a non-pregnant individual. So essentially, bottom line, the cardiac index of 2 is really significantly low and borderline shock for a pregnant lady. So as I said, we stopped the beta blocker and we switched to pure afterload reduction with hydralazine. We used dobutamine for hemodynamic stabilization. The inotropic support can be very helpful in these acute settings. We discussed contraception. She did get that tubal ligation. There are very few cardiac indications for C-section versus vaginal delivery. We can often get by with just assisting the second stage, and in her case, we did try, as long as we sort of limit the amount and forcefulness that they're valsalving and pushing during that phase. It can be totally safe. We really reserve the C-section for obstetric indications if there's oral anticoagulation or severe aortic stenosis. Or intractable heart failure that we just cannot stabilize. In very, very unique, rare cases with patients who are at the time of delivery in shock, we can't get it under control, or there's severe valvular disease, then we sometimes have put sheaths in place. So we haven't hooked them up to VA ECMO, but we just have them there in case. It's extremely rare. I think in the last couple of years, it's only been like once. There was a cohort study of 2,900 deliveries of patients with the diagnosis of cardiomyopathy that found a high rate of intrapartum C-section. So that does necessitate that delivery centers who are hoping to or aiming for vaginal delivery are at least prepared for urgent, high-risk intrapartum C-section. So I think that's worth mentioning. And then some other really important hemodynamic points. It's important to prepare for that autotransfusion that happens following delivery, and that's mediated by the IVC compression from a gravid uterus is now released because the little heavy baby is no longer on it. So we're suddenly allowing a ton more blood flow to get back to the right atrium, and the contracting uterus. So all that blood flow the blood and fluid is just being pushed back. So you're getting a massive fluid bolus back into maternal circulation. So similar to the diabetic lady who got 4 liters of fluid, getting a liter or 2 in a heart that already has very poor reserve could be the difference between, pulmonary edema and desaturation and not. And so we often have BiPAP and IV loop diuretic on hand to try and treat that. It's always a question, and it has to be very individualized about whether or not to give someone anticoagulation when their ejection fraction is found to be low, less than 30%, or the European Society is a little more liberal, or I guess a little more conservative about that, and suggests only, it would be more liberal. It doesn't matter. That when the European Society for Cardiology suggests a higher threshold, so less than 35%. So Lovenox is okay during pregnancy and in breastfeeding. Warfarin's fine in pregnancy. Specifically, it's best for mechanical valves, so we don't want to be kind of shifting to Lovenox. We usually tend to leave people on their warfarin dosing for that, and it's also safe in breastfeeding. We really tend to avoid the new oral anticoagulants like Eliquis or Xarelto. Those are, generally speaking, not used. I have 2 other quick cases that I'll go through. Caitlin, are you able to tell me how much time I have? I'm sorry, I don't actually know.
You've got about 10 minutes left.
Laura. Perfect. Okay, I think I'll be able to finish them all. All right. So quick case 3. This is a lady with ischemic heart disease in pregnancy. She was a 34-year-old female with a history of premature coronary artery disease. Had a 1-vessel CABG less than a year prior, hyperlipidemia, had papillary thyroid cancer. She was now pregnant with her first child. We continued her low-dose aspirin, but did stop her statin. We were able to start her on omega-3 fatty acids, but that was the only thing we could really continue for her lipid issues. Her LDLs did remain greater than 170. She luckily remained asymptomatic throughout pregnancy. She had a normal ejection fraction, normal biomarkers. She did, by the end, develop severe preeclampsia and had to be induced. She did have a vaginal delivery, healthy baby girl, around 37 weeks. She plans to breastfeed and bottle feed. We did opt to restart that statin after sort of a discussion with her, given that her LDL was rising a little bit more than we would have liked to see, and given her underlying coronary disease, we did not want new problems to develop. So, sorry, I did not realize those were not on. Atherosclerosis. There are a couple different reasons for ischemic heart disease in pregnancy. Atherosclerosis is one of the main ones that's very high risk, and so PCI or stent plus dual antiplatelet therapy may be necessary if that were to happen during pregnancy. There's also sort of the more pregnancy-specific potential, which is pregnancy-related coronary artery dissection. Most common in third trimester or postpartum. That's sort of the highest risk period for that. Myocardial infarction in the absence of coronary disease, that could really either be vasospasm, microvascular dysfunction that we can't identify in the catheterization setting, or coronary thrombosis. Lipid levels do rise throughout pregnancy, but they don't. The LDL shouldn't get any higher than 150, and as I said, hers were greater than 170s, and so we did opt to start her back on the statin. All right, so this is the last case. This is about an arrhythmia or channelopathy in pregnancy. So this lady is a 28-year-old female with a history of obesity. She had a VF arrest following delivery of her first child. That was about a year ago. That led to the diagnosis of long QT syndrome, and that led to also an ICD implant, which is appropriate. Anytime you have VF arrest, you should definitely end up with an ICD. She then came to us because she was pregnant with her second child. So our plan was to continue the Nadolol, which she was on already for the long QT syndrome. We continued that once daily throughout pregnancy. We definitely in those patients have to make sure we avoid any long any QT prolonging medications. Unfortunately, that includes a lot of our anti-nausea medications, so be aware of that. Her ejection fraction remained low normal, but for the most part normal, 50 to 55%. Her BNP stayed normal, although she was obese, and it is a little bit less reliable in the setting of obesity. We planned for induction of labor with telemetry monitoring and a crash cart. We weren't sure if she was going to have another arrest. We did have a magnet to prevent unnecessary shocks. If in the case she needed C-section, that cautery, we do have to be careful that it can sometimes pick up and lead to artifact, which makes it think it's in a rhythm that requires a shock. And so we put that magnet over it during C-section to prevent that. She did end up having a vaginal delivery, had a healthy baby boy at 39 weeks gestation via induction. At the time of her delivery, we changed her once daily Nadolol to 3 times a day propranolol. There's better data for it in breastfeeding, and she was really passionate about wanting to do that. And so she was willing to switch to TID dosing instead of once daily in order to do that. So other things to talk about: women with congenital long QT syndrome should have pre-pregnancy counseling due to the increased risk of malignant tachyarrhythmias during pregnancy and postpartum, as was her case. This woman, this was actually a couple of years ago, and she's actually had 2 children since, and has never had any sort of other arrest with any of her 3 subsequent pregnancies. Again, kind of pointing to my hypothesis that as long as we are monitoring her extremely closely, she can have a better outcome. And then, of course, if there's any hemodynamic compromise present with any arrhythmia, treatment is similar to non-pregnant individuals. Most important thing to remember is that cardiac output for mom means cardiac output for the baby. And so we want to restore that cardiac output and good perfusion as quickly as we can. There is data from looking from 2000 to 2012 that shows a rise in arrhythmia-related hospitalizations. Pregnant Black women have a higher rate of any arrhythmia compared to other ethnic groups. And so these are sort of some of the more common ones that we see: sinus tach, atrial or ventricular ectopy. They tend to usually be very self-limited or benign. There are sustained arrhythmias that can potentially require any of these. So digoxin, beta blockers, calcium channel blockers, IV procainamide for wide complex tachyarrhythmias, lidocaine. Those are the 2 that we might have to use. Direct cardioversion, again, if someone's unstable, just shock them, because we need to get that cardiac output back to normal as quickly as possible. And then in some cases, catheter ablation is needed. All right, rounding out the last objective here, we want to appreciate the utility of biomarkers in team-based care. I'm going to go through this very quickly, but basically this study looked at 22 pregnant and 38 postpartum women. Average age was about 32. And they looked at the median BNP was 326 for women with heart failure versus 75 for women without heart failure. So they found that a cutoff of about 110 BNP yielded a 95% sensitivity and 62% specificity for the diagnosis of heart failure in pregnancy, which is actually pretty close to what we consider to be the normal cutoff. 100 is sort of our normal cutoff value for what's high and abnormal versus what's normal and sort of low. So that is it's very reliable, and we, again, check it every time I see a pregnant lady. I'm checking a BNP because it's just one more data point. There's also data for cardiac troponin. So we also check these. And in this study, women with high sensitivity troponin in the upper quarter had a higher odds ratio for preeclampsia compared to women with levels in the lower quarter. And they say right around 1.9 or greater of cardiac troponin may tip the scale toward preventative strategies. So we might want to have extra monitoring, be checking in on their blood pressures throughout pregnancy. I think this was another retrospective looking at 9,000, almost 10,000 women, and they looked at NT-proBNP and troponin in their case as well. Basically found the NT-proBNP concentrations were higher in the first trimester among those who developed peripartum cardiomyopathy versus those who did not. So again, more data for that NT-proBNP. And then a higher proportion of women who developed peripartum cardiomyopathy had detectable troponin levels compared to controls. So this does suggest that there's some subclinical myocardial dysfunction early in pregnancy that we can actually detect that's associated with peripartum cardiomyopathy. We believe here that personalized, specialized care provided by a multidisciplinary cardiobstetric team is really standard of care for every pregnant woman with pre-existing or newly discovered cardiovascular disease, and team-based care is really is just the way to go. There are so many more people involved in our cardiobstetrics team, but I kind of got tired of kind of copying and pasting pictures, so that's some of them. The longitudinal follow-up for these ladies involved from a cardiovascular standpoint, it's medication titration optimization. That's really the long-term thing. An ICD, if it's indicated. Cardiac rehab can be so beneficial. Genetic testing, again, if there's something we can identify, we want first-degree family members to know and be tested. The other really important thing to these women is often future pregnancy counseling. And then in certain cases, like thankfully very few, when it's important to refer to advanced therapy such as heart transplant or LVAD if their heart failure does not get better. So with that, I'm going to end. Thank you all so much for your attention. I'm happy to take questions, and hopefully that wasn't too fast.
All right, thank y'all everyone for joining. If you have any questions, please feel free to drop it in the chat or come off mute.
Dr. Joly, thank you so much. That was great.
Absolutely.
I learned a lot. I do just have, this is maybe more clinical than the group's looking for, but are you not worried about the reflex tachycardia with hydralazine? Does that come into play at all in those with heart failure?
Yeah, it's a good question. Tachycardia from our standpoint, it's a sign that things are not well compensated. Like if I see someone with a bad heart failure and their heart rate's 120s or 130s, I'm like, I know that person's not well compensated. And so, we either, or they're just not well beta blocked. And so, if the rest of the picture is that they are very well, they're euvolemic, they don't have a lot of fluid on board, they are feeling, for the most part, okay, they're not having a lot of volume overload symptoms, then I would just drive the beta blocker up and just try to increase it as much as possible. If, I see that and plus they're volume overloaded, they can't do anything, they have to prop their head up to sleep, they're sort of been miserable, then, you know, I'm more concerned about their overall cardiovascular status and their overall cardiac output at this point. So I think your question is mainly like, does it mask that, or does it sort of give us sort of a false elevated reading, and maybe we are more concerned than we would be otherwise? The answer is that it hasn't really ever happened. It hasn't really happened in that way, and I think one of the main reasons is because blood pressure is so much more, untreated blood pressure is so much more devastating to poor LV function than I think heart rate at any given time. And so if we can bring down that systolic blood pressure, reduce that afterload, then the heart tends to be happier.
Thank you.
All right, we did have a question about when the recording of this webinar will be available. I will try to get it out soon. As far as when it will be sent out, it will be sent out with the email for this action period call. So be looking for that. It should also be uploaded to the obstetric hemorrhage website. If you think of a question later on, we can always make sure that your question gets to Dr. Joly and gets answered. So thank you all again for your time, and we'll be on for just a little bit longer if someone has something that they would like to ask. I think that's it, Dr. Joly. Thank you so much. That was
Alrighty. Yeah,
so good.
absolutely.
And I'm so glad that
Absolutely. I'm
the
glad.
power worked for you.